have something called the Liberati and the Brandera. Not Liberace. So with the Liberati, they used to say that you would do the Liberati movement if somebody had cupulolisthesis. Cupulolisthesis means that when you put them down into the Dix Hall pike and you see them spin, okay, you have nystagmus. After 30 seconds or so, the nystagmus will disappear, it goes away. They'll say, I feel fine, there's no more spinning, I feel good. With the cupola, it means that it stays forever. As long as they're down in that implicated position, they'll continue to have symptoms. So it was a little more challenging to treat those patients. So they would do what's called the Liberati maneuver. The Liberati maneuver is a little more aggressive. Over the years, they've done studies and they found that the Liberati maneuver is still used, but this is more effective in cannon repositioning as an alternative to doing the Dix Hall or the CRT or the okay. So what it looks like is you have the patient, you turn their head, okay. So I'm turning his head to his left, and I'm going to lay him down quickly on his right side, and he's going to stay there for 1 minute, okay. So the person has to have enough strength in their hip and legs to bring their own legs up, because you can't do all that at the same time. It's going to be too tough. So turn your head, lay him down, and bring your legs up. Yep. So I'm going to have him stay like this for 1 minute. Okay. So you can see his right canal is still down, right? Okay. And say 1 minute passes. And his head stays in the same position. Okay, stays in the same position for 1 minute. So this is kind of an alternative to doing the Dix Hall pike on your back, roll, end up on the opposite side, looking down. Okay, the key is, sit back up. I don't want to make you too dizzy. The key is when I turn him this way, his head is facing that way. He's going to lay on his right shoulder, go down. He stays like this. Back up. I play it out again. I have to keep his head in the same position. You don't want to do this, because then you ruin the technique. He's got to be in the same position. That's the caveat with the Liberati movement. This is an alternative to the other. Okay? Canal free position. It's another way to do it. If somebody's in this person for me. If somebody has a really bad thoracic kyphosis, somebody's in their 7th or 8th decade, they have a dowager swamp, they don't have the ability to extend and lay back, then you can't do that repositioning technique, or so you think, because they can't assume the position. If somebody's in a hospital bed, where the hospital bed butts up against the wall, where there's suction units, you can't go to the head of the bed and do it. You're not going to turn them around and put them to the foot of the bed, take off that foot plate, although I did that before I knew how to do this, and try and do that to a patient. You find another way to get them into the position where you can implicate the canal and still do the treatment. So what you do is you get 2 pillows, and you want to make sure that the pillows are about the level of T7 down. So when they lean back, it's going to have to make their head and spine go into extension relative to their trunk. Does that make sense? Mm-hmm. Okay? Sure. So you can do it just like this. In fact, this is what I do in the hospital when I go to TGH and they ask me to do a bedside vestibular eval on somebody to see if they need PPP. I'll do this. I'll take 2 pills and put them down like this. And if they spin, if I'm looking for subjective and clinical information, he'll have a spinning. He'll have a. Even though it looks like his head is down. It is, but his eye is up this way, so it's upbeating the stagmus, torsional, upbeating. So I know that's right, posterior cervical canal. If I see his eye beating down towards his chin, okay, even though it's up, in relation to the table, then I know that it's anterior canal on the left side. If I went to the course and the certification exam, we were all gonna freaked out. Wow, what are you doing that? That's so crazy. The treatment's the same. If you do the upper maneuver, it doesn't matter if it's left or right. It's the same treatment. It makes it easy. Okay, so that's how you modify it with pillows. For the Brandt-Daroff, I give patients who, I took like the nun treatment. If she called me a month later and said, "Hey Pat, I got problems, I have vertigo, instead of charging her another copay and coming in and putting through, before I've let them go, I would instruct them in a home exercise program to do their own treatment. So it's called a Brandt-Daroff. So basically what it looks like is they do this to themselves, and then they report back to whether they have symptoms or not. So I'm going to have you turn your head to the left, right, or the left side. Have you turn your head to the right, lay down on the left side. So now it's his left posterior canal. Okay, so they'll hold, so this assumes that they have adequate strength in their neck to hold the weight of their head up. They can assume this position, and they'll wait for nystagmus if they have it, to fatigue, and then count 30 seconds or count on 30 seconds until after that, then they sit up. And then they have to complete the procedure, and then on the other side. Again, for this time it's a little longer, it's about 1 minute because this is the final position. And then they sit back up.
And what is that for?
This is for a home exercise program for canalicysis or BPPV.
Which canal? That's still
Posterior canal. So that is still for the posterior canal.
But now, I'm sorry.
Yep.
What is the difference between that one and
The liberatory, initially when they first developed this, it was used for liberatory or /SOMAT, S-E-M-O-N-T. That was for people who had pupillostasis. So canalistasis is where the calcium crystal is within the canal. The canal, so big it could be anywhere along that canal. It's within the canal. If you have pupillostasis, the cupula sits anatomically right up near the ampulla. Okay? So the ampulla is the suction, everybody remembers that pulls the crystals back up to go home and live there. Some of these crystals can fall out, head injury, over time for age-related, doesn't matter. They go from the ampulla, and they only travel down, they migrate a very small amount to the cupula, and they stay in the cupula. So how do you know if a person has pupillostasis or canalistasis? Who knows? We just said it earlier. The canalistasis, when you put them down in that position, the nystagmus will go for like 15 or 30 seconds, then it'll stop and it'll fatigue. And the other one, the pupillostasis, as long as you hold them down into that position, it does not fatigue, it'll keep doing it. So then the theory was, if you do the Liberati technique and you do it really fast, you allow that suction to be active and move it back up quickly. So it was initially thought that the briskness of the movement would do that. So what it looks like is, again, you instruct the patient what they have to do, basically bring their legs up on the table while you quickly put their head down to the table. So it's, you turn their head to the side, and 1, 2, pull it out. So really fast, okay? And you hold them here for a minute, and then sit back up. Now watch, back up. You see how fast that went? So the quickness of the movement, they say, helps to do it. What they found, more recent studies done by Schubert, the author of that chapter, and Hopkins, shows that that really isn't all that effective for pupillostasis. They use it as an alternative to the equity maneuver, which you saw in the beginning. They do that.
The first one I did when you like lined me up, but you didn't. Like on this one, I turned my head and then I turned the other way. The other one was I kept my head the same way. Like no matter if I was leaning that way.
Oh yeah, that should have been that. So it should have been here, and then
And then when I laid down,
it should have been.
all right.
It should have been like that. Yeah.
So that's the
That's the liberati. The liberati is you don't have to lay them supine, turn their head.
I guess I'm getting
Lay on your side.
between the two, because one has them reversing the position of their head, the other one's head is leaning
Right.
Yes.
So
Yes.
I when he's bringing him up, when he's trying to do it, isn't
The
the head
one.
in the same place?
Okay. So when he's like, okay. So no, this is important. Dr. Walsh has a very good important question. Turn with your feet toward Dr. Walsh. Watch the position of his right ear. Back up towards me. This canal, the posterior canal, is the one that's implicated. How do I know? He comes in and subjectively says every time I'm in bed and I roll over on my right side to kiss my wife or girlfriend goodnight, my head tips down, I spin. So I know based on what he's told me, he has that right side effect. So I know that's where it is. So when I bring him down, the right ear and the right posterior canal is in the down position to start that nystagmus. Now to treat it, I have to make sure that when I'm finished, his ear is up. So when it's up, you want back there? Here's the canal, here's the ampulla. If the ampulla didn't have the function of being a suction, it's not going to suck that pupil back up. So when he's down here, the crystal has to fall to the bottom because gravity, and that's going to cause the nystagmus. Well, the ampulla is designed to suction and keep them pulled up. So, roll over. So I'm on his side now. Now look at his right ear. Now his right ear is up. So the canal is up. The ampulla, which is the end of the plunger or toilet, sucks that crystal back up. Okay, now, back up. Sucks it back up. So, in this position here for the liberati, so this is an alternative to that position. Head this way, down. His right ear is down. Back up. Go this way. Right ear is up. This is the end position. So mechanically, it does the same thing. The ampulla is still here, trying to suck that crystal back up. So for people who don't like the feeling, and there's a lot of them, and I'm glad Dr. Walsh brought this up. A lot of patients don't like the feeling of having their neck hung over a table and turned. So they don't do that to them. I can't tolerate that. Or if you as a clinician, your patient may have a little bit of vertebral band insufficiency. Is there a way to still treat that patient? Yes. Do this. So when you do this, you're not extending that neck like you would. So it's an alternative. That's how it is in recent studies now. Years ago, as recently as 7 or 8 years ago, it was done this fast. 1 minute, back up. So the briskness of the movement moved and jiggled those crystals to activate. So that's the difference. The brain Darrow is just a home exercise. I give it a home exercise program. Basically, this is what I tell my patients to do if I'm not around. If it's his right ear, I have him turn, he lays down. Back up. Turn. Down. Still up. So basically, you just reverse the position.
And when you're holding, because Epley, you're doing 30 seconds, and then on their side for 2 minutes.
The Epley is a different. Yeah, the Epley. Well, yeah, it doesn't matter whether it's 1 or 2 minutes. You need to get that canal in a position where the ampulla can suck it up. That's all it is.
So for the liberati and that one, how long do you have holding?
At the end position, 1, minimum, more like 2 weeks.
And that's the most important.
That's the most important position to allow that to happen.
So for the brand arrow, so if he turns to his effective side, and then when he switches, so he's in this position here. So when he goes to the other side, does he turn his head or does he keep it?
Here off, he looks
Yeah, it looks like he's heading down.
Yeah, see in the book, that's why it's confusing. They have them moving up and close. They're not versus. Yeah.
It's still not dependent to gravity. Whether his head is like this or his head is like this, it's still able to suck. It's not down like this. So mechanically, it still works. It still works.
So you can literally do a brand door off the same way you do a seat.
The CRT or the upper.
Yeah.
Yes.
Okay, and
Yes.
correct.
Correct.
Okay, that's why it's confusing.
In the liberati is what they sometimes do have patients who can't tolerate the neck extension. I don't do the Branderoff in a treatment. I do the Epley in a treatment. At home, I describe to the patient the Branderoff, or if I've done my job correctly, at the time that I did their veil, I'll show them. If this comes back at home, this is what you do. I'll give them a printout. I'll give them a printout of the Branderoff, and I'll show them how to do it. And the goal is, if they're symptomatic, they'll do it 5 repetitions, and they'll do it 5 days in a row. And they have to get to the point where they can go 2 days in a row with no vertigo, and essentially they treat themselves. And it does work. It is effective that way. It's not as good as you doing it in the clinic. Sometimes patients can't always come to the what time is it, Josh? Okay. For the clinical test of sensation and integration of balance, real quick, basically there's 6 different conditions. So condition 1 is standing on a flat surface, arms crossed, eyes open. Condition number 2 is flat surface, arms crossed, eyes closed. Condition 2 or 3, up here on a compliant surface, a low or high density foam, arms crossed, eyes open. So now here, what's working? Visual, vestibular, somatosensory. Now I want to take one system away. I want to alter one system to see how my body reacts. So I'm gonna alter the proprioception. And I have them go here like this, and now I do the same thing. Eyes open. If I want to alter the vision and the proprioceptive, just close the eyes. When you're doing this, patients should be able to hold their balance for 30 seconds, eyes closed, arms crossed. If they do this, it's still within normal limits. If they do this, which is an acute writing reaction, they fail. If they open their eyes, they fail. If they have to step off, they fail. Same thing if they do it when their eyes closed. Same here, if they writing reaction, eyes open. Okay. I need that wedge.
Foam.
Foam. I need the foam.
You mean my computer?
With a machine called the Balance Master, it looks like one of those photo booths where you go in, take the pictures of. It's a machine that you stand on a force plate, and the force plate will keep you stable, and it'll alter the visual background, and then it will also move the plate laterally anterior posterior to see how you so there's 5 conditions 5 and 6 alter your foot placement and your balance. So you can simulate that by standing up on a wedge. And now you're doing this here, and you do the same thing. So in a pinch, you can kind of simulate conditions 1 through 6 without a balance wedge. In the clinic, most people don't do these. When I was, doing it in my clinic with the Vestibular, I would have them on a foam wedge, and now I really want to test this. Okay, so that's the test. There's another test. Who has it going on there? You guys are going on there? You got it. This is a fun test. This is a fun test. So you take, and you can do it with a grid, usually a piece of tape and a grid, but you get it to about 30 degrees, okay, and then you put it down. So the test is called the Fukuda step test. The Fukuda step test. And so the theory was it's not all that valid. So the validity of this test isn't very specific to ruling in vestibular deficits. It can be some balance abnormalities or cerebellar problems. However, they still tend to sometimes use this. So you stand with your feet in a comfortable position, and you're facing in one direction, so your brain cognitively knows straight ahead. Put your arms out, and you tell your patient, okay, march in place for 1 minute. So when they march in place for a minute, if there's norms, there's a ton of norms, there's norms with this. So if you back up, I think it's 12 inches, one foot. So if you go backwards or forward 12 inches, that's within normal parameters. If you rotate 30 degrees or less to one side, that's within normal. But if you rotate more than 30 degrees, that they say correlation indicates a vestibular illusion to that side, to the side that you rotate towards. So it's kind of a fun test. But
I don't know they still use that. Well, that's interesting. I used to.
yeah. So that's that. All right. So habituation. When do you want to use habituation? People have they have visual vestibular mismatch. So if somebody gets dizzy when they're going from a seated position and they're standing up and looking to a corner, or just thinking their head and looking down and looking up, they can get dizzy. So I'll have Antoine lay down. Where is in the book motion sensitivity quotient? Okay, so did Josh have a book?
That's my book.
Okay, so lay on your back.
Which page are you
No. Okay, no.
He was just asking if he had a book.
I want to make sure I don't miss anything. I mean, I think I have it memorized, but make sure you basically want to do all the sitting. All the ones that are sitting. Do number 9. 14. Timmy, you stand up and do numbers 15 and 16.
I'm the 14th. Oh, what do I do?
So
Those toward left knee.
but you're sitting.
I'm doing it?
Yeah,
I'm doing it.
That's why I gave you a book. You're sitting down.
I'm gonna do it.
So watch Josh. So do those different positions.
Nose toward left knee.
Okay. That's nose towards Josh.
Oh, right there.
It's all right. So basically,
Oh,
again,
like down.
Like that.
what you're doing is this. Back up. Back up. No, you're fine. If you think about when you guys go on a roller coaster, the first couple of times you're nauseous and dizzy, but you will habituate or compensate. Not compensate. You will habituate to the particular movement. So the theory behind this is that you train somebody to do these provocative movements over time, and their body will become less noxious to the particular stimuli. So if he does 5 in a row where he brings his nose down to his left knee and he goes back up, that's 1,
Keep doing it.
2,
Make it provocative.
3.
Nobody knows what it means.
Stop filming this, Jonah.
There you go. So if he reported a certain sensitivity on a scale of 0 to 5, then you would add all these up and you would get a score. You can use this to make goals, send it to the insurance company, and so forth. And then do the other one.
Don't let you.
You can sign. And then the other one is head rotation side to side. Yep.
Okay.
Okay.
We had 2 hertz here. What
No, just side to side. So it's just the motion. So this is not for VOR. If it's 2 hertz, then it'd be adaptation exercise. And then it goes up and down. So basically all these different planes of movement. Okay? And for Antoine, for laying down, you go roll from supine to your left side. And then you will hold this position for like 10 seconds and then come back. And then roll to your right side. So this can work on habituation, it can work on bend mobility, muscle strengthening, and so forth. You can go from supine to sitting. So if somebody has any spinal problems, it's very important. If any back problems, osteoporosis, do not have them sit up like this. That adds your stomach muscles contract, and the lever arm can make a vertebral body. If you have a fracture or if you have osteoporosis, can make it a lot worse. So what you want to do is you have them roll to the side. You want to sit up, and that's what you want. So supine to sitting. And then when you're standing, I think we have 2 to do when you're standing.
Yeah, it's just 180 to the right, 180.
Okay, so some people who have a similar problems, when they do that, if they turn, all the way this way, during the movement, it won't be a smooth turn. It'll be like, and they'll get dizzy. So you have to watch them when they do it and then correct them and say only turn, say 90 degrees. Okay, so that's the motion sensitive quotient. How you use that for exercise.
Does it matter if they turn their head and follow with their head, or if they like turn like?
Yeah, it does. Good point. So if a patient turns robotically as one unit, they don't dissociate their neck from their trunk, and they turn like this.
Very flat.
You want to have them, you want to instruct them, turn your head and then turn, so the body will follow the head. So that's how you want to have them do it.
Well, they tend to do that mock turning if the turning of the head is provocative.
Yes. Yeah. If the turning of the head is provocative, so they turn their head and they go, "Wow, I'm dizzy." They don't want to feel dizzy, so they're not going to turn their head when their body's facing this way. They're going to turn their body and have their head follow.
And then they'll tell you that they're not physical. It's not provocative. You have to make sure that you're doing it correctly.
So the difficulty, the buy-in for this for patients is that you have to explain to them the difference between you had physical therapy in the past for your total knee, for your impingement, you did muscle exercises, posture, modalities. Vestibular rehab, there's none of that stuff. It's much different. These are designed to make you less dizzy when you play with your grandchild, when you go grocery shopping. You tie a function into movement. Otherwise, you're going to say, "This is stupid. I'm not going to do it." You have to make it functional for them and plausible.
What does provocative mean? Is it like dynamic?
Provocative means the movement that causes the symptoms to occur. So you're provoking the movement.
Now you know what it means.
Exactly. Why don't you guys break up and try that Dix Hall Pike if you guys have it. Try the adaptation, and then try a few of these habituation movements. Try sitting on the phone, and then we'll come around and